Isn't it interesting how everything can change in just 1 week? Did anybody see this coming? Yeah, there have been some fundamental changes down at Race, and I mean, you can look at it from the perspective of, oh, it's just a patent. What's the big deal? But in reality, what the patent represents and how it has now dramatically changed the company to effectively owning 2 commercial assets it's compelling. It's very, very exciting, and I think it has brought forward a commercial event, and it is part of the strategy. And Tuesday for me, it was that first obvious step forward towards commercialization, and it's exciting. I'm ready. I suppose for those that do not know who I am, my name is Mason Hill. I have a degree in nutrition and a master's of dietetics, and I've been following this story for a little while now. It's compelling, and I had a lot of conversations with people during the week, and I got the impression that perhaps the significance of the events weren't completely understood. So I thought that I would put something together so that it became quite clear, and perhaps maybe use a little bit of terminology that's easier to understand. And so hopefully this has the desired effect. So what's basically happened is Race discovered that the original bisantrene formulation was impure. It had an active ingredient and an inactive ingredient. Now, you could kind of think about this as, let's say the active ingredient is fuel, whereas the inactive ingredient is water. The fuel is good for the engine and it helps with performance, but the water doesn't really do anything. And so what they've basically done is been able to purify the solution and only have the active ingredient. There is only fuel now. And this has effectively created a new drug. So you have the active isomer, the fuel, and you have the inactive isomer, which is the water. And so this is what we want. This is doing all of the anti-cancer lifting. This is doing all of the cardioprotection. And we want to try and maximize as much of the active isomer that goes into a patient as possible. Now, what they found was that light and temperature, and I think there's also a chemical reaction that can happen as well, shifts from the active substance to the inactive. And it can kind of be a little bit confusing to understand how that happens. And so a really simple way of explaining that process, because both molecules have all the same atoms as the bisantrene molecule, they just rearrange differently. And so imagine that you're watching a sunset at the beach, and the sun comes from behind a cloud and is quite bright. Now naturally you would raise your hand up in front of your eyes to guide your eyes from the light. And so in that moment, nothing has really changed about your physiology. Nothing has changed about your biology. But your orientation in 3D space has changed relative to the light. And this is a similar thing that happens with the active and inactive form of bisantrene. And so nothing about the molecule has actually changed. It's just its orientation in 3D space when it's impacted by light. Now, this changes the way the molecule functions within the body. So the idea is to not have light impacting the molecule, so that you can maintain the active isomer to the highest concentration possible, because this is linked to the anti-cancer effect and it's linked to cardioprotection. Okay, so this is where it gets interesting. You have before the 16th of September and after, and I've got an asterisk here, and I think the asterisk is important because Race have clearly stated that they've known about this for a very long time. So much so that in the two most recent AML trials and the current cardioprotection trial, they've been using the purified active isomer. And so this figure isn't completely true, but to hold it as a concept in our minds, I think it's much easier to understand what's actually happened and what's changed. And so before the 16th of September, you could think of the RC110 program as the original bisantrene formulation, where it had an unknown ratio of the active and inactive isomers. This was generic, so it was not protected by patents. It wasn't necessarily a great commercial asset. And then you had the RC220 program, which had the original bisantrene formulation plus this advanced drug delivery technology. Now, this was a new drug, and this was the figurehead of the company. And yes, it was bolstered by the clinical history of bisantrene, the original formulation. It was patented for 20 years, and it was the focus for us. And so the dramatic shift on Tuesday, my goodness. So we go from having a generic, not necessarily a super commercial opportunity, and a patented drug, to now having effectively two patented molecules, two commercial assets. Yes, the RC110 program still has the limitations of crystallization in peripheral veins, but it is at phase 3 molecule with a 20-year patent life. Unheard of in the industry. And I guess I'd like to just touch on here, yes, the RC220 program is significantly larger. You having the ability to deliver RCDS1 peripherally opens up so many more cancer types, so many more combinations. But what happened on Tuesday, the real increase in value within the company happened with the RC110 program. It had gone from, previously being a generic and not necessarily super commercial. I mean, you could probably make it work, but what it is now, it is an exciting, it's on the doorstep of approval, and it has a 20-year patent life at phase 3. The change in value of RC110 before Tuesday and now is unbelievable. And effectively Race acquired, they've acquired a phase 3 asset, a phase 3 ready asset, at virtually the cost of preclinical work and no dilution to shareholders, which is unbelievable. It's just fantastic. And so I just kind of want to focus on this for a little bit. And I think this makes it a little bit easier to understand. There's really kind of two key points with the new purified version of RC110. It has increased substantially in value relative to an older, impure version of itself. But it's also increased substantially in value relative to any other drug that is going through the typical drug development process. And this little figure helps explain why that's the case. Imagine you're in a parallel universe. So things are happening identically in two different places at the same time. You have the impure RC110 program, and you have the purified version. Now, you initiate a phase 3 trial. Let's say it's exactly the same, the exact same patients, and it reaches approval at the same time. The impure version will have a 7-year window where you can commercialize the asset, after which any generic can be made by a competitor, and they would take away market share. You have that 7-year window to commercialize this asset. Not very attractive. However, if you have the pure RC110 program that then gets approved, it still has the 7-year exclusivity period, but then the composition of matter patent extends well beyond that period. So you can still be earning from this drug uncontested with generics up until 2045. So the value of RC110 now is substantially larger than its impure predecessor. Similarly, any typical drug that goes through the drug development process, their composition of matter patent would probably go in quite early in the stage of development. And so it's effectively a race, pardon the pun. From the moment that patent goes in, you have to race through clinical trials so that you can try and get to approval as fast as possible so that you can maximize the commercial validity of the asset. And so now, if you hold this pure version of RC110 that is sitting ready to go at phase 3, and you compare it to any other drug that not only has to face the time to get to phase 3, but also the risks involved, all of a sudden, this simple little program that was seemingly not valuable has become extremely valuable. The program, if approved, would stay in the market and would be a commercial asset for significantly longer than any other drug that goes through the typical drug development phase. So yeah, there's been a monumental shift in the value of this asset, and it cannot go overstated. I've jumped ahead and I've showed you some of the goodness. So this graph, I think, really, it highlights how different these molecules are, and it helps people understand, like, oh, okay, this is why it's now considered a new drug, because a patient is receiving a completely different biological agent. The red line here is for the impure version of RC110, or the generic bisantrene formulation. And I guess to understand this graph, you kind of have to start to think practically about the impact of light on a solution, the original bisantrene solution. As we know, light will start to move the active isomer to the inactive as it pulls its hand up to shield itself from the light. Now, this can happen at just regular indoor ambient light, and it happens very rapidly, so 1% per minute. And so I think if we think about this practically, the pharmacy gets a notification that a solution of bisantrene needs to be prepared. They whip up this solution, and for every minute that solution is exposed to light, there is less and less of the active substance remaining within that solution. So the active isomer, as it correlates with anti-cancer benefit and cardioprotection, you are having less and less amounts of that isomer to elicit the response that you really want to see. And there are two key time points here that we need to consider. Now, I've termed the first the pre-exposure, and really it's the time from the moment that the solution is prepared and light interacts with it, and the moment the first drop of the solution makes its way to a patient. Now, whatever time span that is, and assuming that the solution has a constant amount of light interacting with it, you will see this decrease in overall percentage of the active substance. And this is assuming that it's 100% at the start. It may not be. And it's termed the pre-exposure. And this will set the maximum percent concentration of the active isomer the moment the drug touches the patient. Okay? So any time frame here could have happened in the historic clinical trials. You could have had a rapid creation of the solution. A nurse picks up the solution, runs down every hallway required to the patient, link up the IV bag, and start pumping in 15 minutes. Or it could have sat on a benchtop for 4 hours before it was actually given to the patient. Now, each of those time frames, there is a different length of time where light is interacting with the solution. So a patient could receive a concentration of the active substance anywhere along this line. Now, I don't know about you, but I don't think cancer patients get treated in the dark. So the next time frame is after the patient has received the first piece of the solution. Because if there is ambient light in the room, the concentration in the bag will continue to decrease by 1% every minute. So in effect, the first drop of a solution is going to be the highest concentration of the active isomer, and then the concentration of the active isomer will continually go down every minute thereafter. So the patient is progressively getting less and less of the drug. And so if we now compare that to the orange line at the top here, this is effectively what RAC have done. They've created a solution where it is only the active isomer, and so you do not have this decay or this shifting or this decreasing in concentration of the active substance. And it's really this difference here. This difference highlights the uniqueness of RCDS1 relative to the original RC110 or bisantrene formulation. It's a different drug. It's completely different. The thing that you really need to potentially hold in your mind is, what happens if we actually give a patient 100% of the active ingredient? Bisantrene was previously approved for AML. It was successful, and the entire time it has had a limiter placed on its engine, unable to really stretch its legs and work. And I, for one, am very, very excited to see how this begins to play out clinically. So here it is. Here is the clinical history for bisantrene. It's been very, very widely studied, and I have to say, when the hell is this drug going to stop just giving out surprise after surprise? Every time that I think that I'm getting a handle on this thing, and I can start to really look at this clinical history with some confidence, I'm just throwing curveball after curveball. And you know what? I'm here for it, but it's honestly like trying to solve a jigsaw puzzle with the pieces upside down. Anybody who doesn't understand the context behind the drug, there's no way that they're going to be able to look at the clinical history and make any sort of strong conclusions. Yes, it's safe and tolerable, but the efficacy, it's all up in the air, in my opinion. But what I really wanted to show here is kind of what I really wanted to show is that these two compounds, the purified RC110 compound and the purified RC220 compound program, they are backed by an enormous amount of clinical history. And so what's effectively happened is we have two now commercial assets, with one sitting at phase 3, knocking on the door of commercialization with a 20-year patent life. And we have another one that is a technological revolution, and it opens the door to the entire cancer market and solves a real problem that had prevented the first drug in the first place. And so each compound is bolstered by a huge backing of clinical efficacy, approval, all while being hindered in its ability to actually function. It's impossible to really know how much of the active substance made its way into each patient. All we know now is that both the RC110 program and the RC220 program are purified active isomers, and they are bolstered by a very large clinical history. Okay, I kind of touched on it before, but this is another thing that people have been confused about. We now have the purified versions with the RC220 program differing because it has the advanced drug delivery technology. RC110 still has the crystallization issue that has not gone anywhere. You need to deliver the drug through a central line, and it's perfect for hematological cancers and orphan diseases. However, the RC220 program builds on this compound, this active isomer, and enables peripheral administration. This is perfect for solid cancers where they're not going to put someone, they're not going to create a central line for a breast cancer patient. It just won't happen. And so, yes, the RC110 program still has its inherent, limitations. But that doesn't change the fact that it's now become a very strong and potential commercial asset. And relative to itself, before Tuesday, if you want to think about it like that, and relative to virtually any other drug that's going through the typical drug development timeline, racing their way up to a phase 3 and approval, the value of the RC110 program has increased substantially. And this really explains why the market has reacted the way that it has. In my opinion, a commercial event, if it was ever to arise, has just gone from way out in the horizon to feeling like it's staring you in the face. So yeah, that's pretty much it. I hope I haven't bored you guys. Effectively, Race have acquired a phase 3 asset. They've gone from a phase 1 exciting, de-risked phase 1 development program to now a company with 2 commercial assets, one sitting at phase 3 with a 20-year patent life. They can then sell off perhaps maybe the smaller opportunity and then allocate non-dilutive funds to the larger opportunity and really expand out the use case. As I said at the start, I think that this has been a careful step forward towards commercializing their assets, and it is beginning to get very, very exciting. So yeah, with that, thank you very much for listening. I hope that has helped people understand the significance of these events, and personally, I am so excited to see what the next 3 months bring. Let's see if we get ourselves into a phase 3 trial and how we access the funding. But thank you very much. It's been a pleasure. I'll see you on the next one.